So it started on the Wednesday, probably the Tuesday evening, where I was getting discomfort in my leg, and I had got varicose veins in my leg, but they were playing up. And Wednesday morning I realised it was more than just because the leg seemed to be swollen, my foot was swollen.
This was a gentleman who didn't have a previous history of a DVT, but presented with a swollen leg, which he'd had, I think, for several weeks. He'd done a very, very long car journey, actually to France, and had noticed that he developed a swollen leg following that. And he'd contacted his GP, and then he'd been referred on to us.
I was given a blood test that evening. A nurse came out and gave me a blood test, because I'm a bit of a wuss when it comes to injections and especially taking blood, and they were very sympathetic.
Once the patient has been assessed by the POI team, they will call it through to the GP depending upon how the blood results are. The hub GP will decide whether the patient needs scan booking or not, depending upon the D-dimer.
As soon as we suspect a blood clot in somebody, we're able to prescribe them a blood thinning medication called apixaban. This starts to reduce their risk straight away of the clot extending, and reduces their risk of a part of that clot breaking off. We're able to prescribe that medication, and we can send it electronically to their local pharmacy for them to collect.
I got a phone call, I think from the hub, the next day, and they explained that I'd got a scan booked at the QE2 for 11 o'clock on the Friday morning, and they'd also organised a further blood test. So I had blood taken on the Thursday morning. I then went for the scan on the Friday morning, and I actually had a phone call Friday afternoon from the hub saying that the scan had come back clear. May I just say, and this isn't an advert for the NHS, but all of the staff that I met were terrific.
From the time we have started DVT pathway, HCT Prevention of Admission team, it's working really well, and I can see that there are so many DVTs that come through, and they are being dealt well, and there's a good feedback from patients and also from the doctors.
At the start of the pandemic, we recruited GPs to sit in our referral hub to really help with our prevention of admission service, and they've sat centrally, been able to give advice to multiple different teams on the ground. Because we're a multidisciplinary team, we can also offer services to people who've had a decrease in mobility or a fall, but that multidisciplinary approach to that with a doctor, a nurse and a physiotherapist is really important. So we treat infections, and we have IV, we can give intravenous antibiotics as well as oral antibiotics for infections. And we've also been able to offer subcutaneous fluids in the community for people who are a bit dehydrated but don't need to be admitted to hospital. And because of our uptake of our technology, we've also been able to use video consultation so that the GPs can consult with a patient. And we've been able to do video consultations with people who've been seen by the East of England Ambulance Service, with people who've been seen by the Discharge Home to Assess team, and with our staff who go out to see people routinely and find there's a problem when they get there.
I had some sort of severe gastric infection. I didn't know, my husband didn't get it, I did. I was really ill. I lost a stone in 4 days. And when I got to phone my doctor on the Monday after being ill for 4 days, he referred me to Dr. Paz and to the hub, and then the nurse came in, Wendy, the matron, took the history, and from there on it just picked up speed. And it was wonderful, absolutely wonderful. I've never seen anything like it. People took care of me so well. And the great thing was that a doctor, Dr. Paz or a colleague, phoned every morning to tell me the results of the blood test from the day before, to let me know that I was going in the right direction, because they asked me to do certain things and to be very well hydrated, and I did everything they asked me to, and it was very nice to hear from them.
And one of the main issues with COVID, I suppose, is that patients weren't able to have simple things done, like go for a blood test or to have their observations checked, because we were trying to keep all patients out of GP practices as much as possible. The GP requested our district nursing team to do some blood tests. They did the bloods, and then they came back really, really abnormal. So her kidney function had deteriorated, so she was pretty much in stage 4 kidney failure. And ordinarily we would actually admit these patients to hospital. We were quite confident that the kidneys were struggling because she was dehydrated, but actually normally you'd like to give intravenous fluids, you'd like to hydrate them in a controlled way and keep a really close eye on the electrolytes or the minerals in the blood. So we got these results, and I spoke to Sandra about them and was very honest with her about how the drop in her kidney function was quite serious, but she was adamant that she wanted to stay at home.
I didn't want to go into hospital because our local hospital is a COVID hospital and I didn't feel comfortable going there. But I did say if I could stay at home, I would follow every direction they gave me.
So we gave her electrolyte replacement, some tablets with magnesium and potassium in. She had daily bloods, daily visits from the district nursing team, and we were very careful to monitor her intake and her urine output, and she did really well. We also stopped some of her medication that was causing problems, so we had to monitor her blood pressure in case that went up. And she was under the prevention admissions team, I think, for about 7 to 10 days. And then when we felt she was ready, we discharged her back to her GP, detailing what we'd done, and with a plan in place really for them to just check her kidney function a couple of weeks later.
Because we use FaceTime a lot for family in America, so we're quite used to seeing it, you know, so yes, it was good, and it's very nice to actually see a doctor these days because nobody sees one. We just speak by telephone normally. Yes, very good. Once I felt better, I realised how fortunate I'd been to have such good care from the nurses and the doctors.
Nevitz Care Home is quite helpful because we have a good rapport with the staff there now. So what tends to happen is they add patients to our ward round list. If there's new admissions, they add them to our list, and we tend to talk to the staff first. In the same way that we, would talk to Sandra on the phone about what was going on, and then we use the video to look at the patient clinically. We might have the nurses there who have done some observations, some blood pressure checks, which is similar to Sandra's case, to collect that information. And really we're just using all the resources we can to get as good a picture about what's going on with the person, to make the safest and most effective plan possible. They've really valued having access to us whenever they need it, just to check queries, to get medication exactly when they need it, but also being able to know that there's going to be regular reviews, that they're not on their own with these patients. We can explain things to patients, and actually I've been surprised at how the older population have actually managed really well with the video. They think they've quite enjoyed having chats with us, engaging with the video, and because some of the patients have stayed in the Nevitz for a few weeks, we do get to know them, and it doesn't feel that different to normal general practice when we're seeing people face to face. From a care home point of view, I can see it being the new norm, because quite often when we used to do rounds at care homes, we wouldn't necessarily see every patient anyway, and the amount of time it would take on a weekly basis, kind of finding the patient, finding the notes, made it very inefficient. So I think in that way, I can absolutely see GPs using remote technology a lot more.
During the height of the pandemic, if there was an outbreak in a care home, we deployed a prevention of admission nurse with an iPad, and we were able to do video consultations and ward rounds around 14 patients in a care home who were unwell, to support primary care and to support those care home staff where they had multiple sick patients at one time. This fits really well with some national things which are going on. Same day emergency care is normally considered an in-hospital service, and we've shown that you can actually provide it really well in the community before anybody actually hits hospital, and the point of care testing has enabled us to get really rapid results back as well. And it also fits nationally with the Ageing Well agenda and the rapid response within 2 hours. We've set these services up in the pandemic, but they're really important going forwards to stop people who don't need to go into hospital and potentially having complications of that hospital admission, but also to enable people to be treated as close to home as possible.